Well, welcome everyone. We're going to be doing the clinical intersection of optometry and mental health, what every OD should know from an OD turned therapist. I'm really excited to have Dr. Dennis Pardo, a residency trained OD who graduated from the New England College of Optometry and also holds a Master's of Public Health from Yale University in Healthcare Management. After more than 20 years of optometric experience in clinical practice, teaching, learning, and medical affairs, he embarked on a career as a licensed psychotherapist and obtained his psychotherapy training at the Smith College and Harvard University. He currently runs a private mental health practice and conducts lectures and workshops, which we're going to find out tonight with the lecture, on a variety of mental health topics, including how mental health intersects with optometry. Dr. Pardo does psychotherapy with people over a wide spectrum of clinical issues, including anxiety, depression, ADH, OCD, PTSD, and life transition. Dr. Pardo, I am so looking forward to hearing this tonight. I hope you hear that virtual round of applause as the OEC crowd welcomes you.
Well, thank you so much, Dr. Caldwell, for that very kind introduction. I'm delighted to be here tonight. And, I was telling Dr. Caldwell before we went live why I developed this lecture. I got a wonderful education at NECO, and all the optometry schools deliver a wonderful clinical education for us as optometrists. But the one area that I felt like I didn't get enough was the psychology of what we do every day. And so when I became a psychotherapist, part of that decision after I got licensed was, you know what, I want to kind of provide this information to my fellow ODs to give out what I felt I didn't get. And so this lecture is not designed to turn you all into psychotherapists. That's not why you're here. And I'm sure that's not what you want to do necessarily, but it's to really give you sort of a mental health 101 about what we need to know as ODs with the vast number of psychological issues that we face every day. So that was really the impetus for me to develop this program. And I'm hoping that you really get something out of it to really bring to your offices. And I hope it really helps you with your day-to-day practice with your patients. So I want to say a special thank you to OEC for inviting me, specifically Dr. Greg Caldwell and Dr. Joseph Selka. I want to thank Vanessa McDonald, fantastic to deal with as a speaker. My experience was just wonderful. And I want to thank all of you for taking a Tuesday night after a long day at work for attending today. I saw a full book of patients today too, so I'm going to try to make this enjoyable and informative for you after a long day. So I have no financial disclosures, and we'll be doing questions either interspersed or certainly at the end. And my background, as Dr. Caldwell mentioned, is a bit unique, to say the least. I'm first and foremost an OD, NECO grad, residency trained, MPH at Yale. And, mental health is a public health crisis right now in our country and in the world. And I don't have to tell anyone here that the COVID pandemic really exacerbated mental health issues for people. And fortunately, people are seeking mental health services more and more, and stigma is reducing because we all wrestled with mental health issues during the pandemic. And so I've taken my 20 plus years of optometry experience and clinical practice, teaching at NECO, lecturing on a variety of ocular disease topics, and in my time working in medical affairs. And to combine that with the other side of what I call a two-sided clinical coin, and that is to bring my psychotherapy experience to be able to present this lecture from both sides. So understanding what it's like to be an OD and translating what I've learned as a psychotherapist to things that I think could be very, very helpful to you. So I got my training at Smith College's master's degree in clinical social work program because they had a concentration in what we call psychodynamic psychotherapy. So they train therapists mainly to go into private practice and to see patients clinically day after day. And that's exactly what I do. And I worked in a variety of settings. I worked at a clinic that I worked exclusively with clients that are diagnosed with schizophrenia and a concomitant substance use disorder. I worked at Harvard University's counseling center where I did therapy with undergraduates and graduate and professional students, including Harvard medical students, as well as Framingham State University in their counseling center. And now for the past 3 years, I've grown a practice full time called Tranquil Waves Psychotherapy. This is my office. It's completely virtual. So this is where all the magic happens every day in terms of my career as a psychotherapist. And I really thoroughly enjoy what I do and do this full time virtually and am at capacity. I can't accept new patients at this time because it's super booked, which is the case for most psychotherapists. There are a lot of people out there that need our services, and there are not enough of us out there to provide them. So why is this topic relevant? Like, why am I even talking about this? Well, as optometric physicians, we're the primary physician for the eye, right? So we may discover physical health issues. Diabetes is one of the first that comes to mind, right? How many of you have been the first to detect diabetes in a patient who may not be seeing a primary care physician? They came in for a contact lens renewal, they're a new patient to you, you dilate them, and boom, there you go, right? Well, mental health is no different. We may be the first to pick up on mental health issues. And so I think is our role as primary care physicians for the eye. That's one of the reasons why it's very, very important. As I mentioned, mental health is a public health crisis in the US today. We talked about how COVID really exacerbated that. And the emphasis of healthcare these days is to provide sort of integrated, collaborative, holistic care, right? So, as an important member of the healthcare team, we need to establish relationships with a variety of other healthcare providers. And I would argue outside of other eye care professionals. Obviously, we need to refer to cataract surgeons, vitreoretinal specialists. But I would argue, just like we might refer to an endocrinologist, we want to actually have one or two mental health professionals in our referral in case our patients are not connected with a mental health provider. More of our patients are taking psychotropic medications. They're widely prescribed, some of which have ocular side effects that we need to be aware of. So I have a very brief section on the psychopharmacology as it relates to ocular side effects. Serving your community, as with other healthcare professionals like physicians, dentists, nurses, pharmacists, we provide resources for our patients, right? And that may be interacting with our community, doing screenings, and school-based work. So our role as serving our community is just as important as ODs as it is for other healthcare professionals, I would argue. We are mandated reporters, just like other healthcare professionals, for abuse and neglect. And what does that mean for us? What are some of the psychological issues that can present themselves with that very important responsibility? Referrals to local mental health providers is an opportunity for cross-referral and practice growth. Believe me, if you refer someone to a mental health professional, they will thank you by referring back to you for patients who may need to see an OD. And lastly, what about us? We're human, right? We have stress, we have burnout. So I'll talk a little bit about physician burnout, what that looks like, and what mental health might mean for us as ODs. How can we improve our practice lives and our personal lives by seeking services if we feel we need them as well? So that's an overview of why I think this is relevant. So I was telling Dr. Caldwell that I developed this lecture about 4.5 years ago. And I had hoped it would take off because when I talked with ODs that I respected, they said, this is a topic we need information on. And it did end up taking off. Just this month alone, over the past month and a half, I've done 3 of these lectures. And I had the honor this year of being one of the 3 panelists for the Academy of Optometry's plenary in New Orleans, which was an amazing experience for me, one of the highlights of my career. And the topic was optometry and mental health. And I was the only OD sort of talking about these issues that I will be talking with you about this evening. So cover article in Optometry Times back in March of 2021 on this topic. And that really increased the awareness. And then followed shortly by a review of optometry article on the same topic, but a little bit of a different slant. And I've also done several podcasts, including the Power Hour, on how mental health issues and paying attention to those issues with staff and for yourself can help grow practices. And so that was a very, very interesting podcast with a different slant. So this information is definitely, it's the need for it has grown, and I'm delighted to be able to present this information to you tonight. So this is a broad overview of, what I call mental health 101 for the OD. And basically, it's a survey of the major mental health conditions that I think you will end up seeing in your chairs and on your intake forms. And so with that, we will kind of dive right in. No lecture on mental health could be without talking about our version of the Will's Eye Manual. Back of me in my bookshelf, I have 5 editions of the Will's Eye Manual. I used it voraciously as an optometrist. Our version is the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders. So any kind of therapist, psychiatrist, psychiatric nurse practitioner, this is what we use to diagnose our patients. And it's the go-to definitive clinical manual for all of us. This is the 5th edition, hence the DSM-5, and it's updated about every 12 to 15 years by the American Psychiatric Association. And so this is the definitive reference to the clinical slides in this section that I will be presenting to you. So I wanted to give you a snapshot of what it looks like and that this is what we use. So anxiety and depression are the number 1 and number 2 thing that I treat and work with my patients. And they often go together. They're a marriage made in heaven. It's very rare to see anxiety without some degree of depression and vice versa. So when we think about the bucket of anxiety disorders, there are many. I wanted to cull down the major ones that you will see. And certainly GAD, or generalized anxiety disorder, is one. As you will see, we have lots of acronyms, just like we do in optometry here in mental health. So GAD is the generalized anxiety disorder. The prevalence is quite high at 2.9%. And as with everything, the diagnostic criteria are very defined. And usually what we'll see is frequency, length, that this has been happening, and at least a couple of key symptoms or hallmark symptoms that need to be part of the diagnosis in order to make the diagnosis. One of the things that is in every one of these conditions in the DSM is that it must have a clinically significant distress or impairment in the major spheres of our life: social sphere, professional work sphere, and other important areas of functioning, relationships, you name it, all the spheres of our life. There must be some clinically significant distress. So for GAD in particular, there's anxiety or worry that's difficult to control. So it needs to include at least 3 of the following: restlessness, being easily fatigued, difficulty concentrating, irritability, muscle tension, or sleep disturbance. And you may be saying, well, hey, I have some of those things. That doesn't necessarily mean you have a diagnosis of GAD, right? It needs to be more days than not for at least 6 months. And so here we have sort of frequency and length of time that symptoms need to be present in order to make a definitive diagnosis. Because all of us have had some of these things that I delineate here in our lives, but we need to have all of it put together in order to have a diagnosis of GAD. Panic attacks, very common. We call it panic disorder. The prevalence is again high, 2 to 3%. And the diagnostic criteria is an abrupt surge of intense fear or discomfort with 4 or more of the following symptoms. So palpitations, sweating, shaking, shortness of breath, choking sensation, tightness in the chest, nausea, dizziness, I feel hot, I feel cold, numbness, detachment, fear of losing control, and fear of dying. So many people show up in the ER with these symptoms and they think they're having a heart attack, and it's a diagnosis by exclusion that after doing some baseline tests, the ER physician or nurse will say, you know what's going on? It's a panic attack. And most times people are shocked because you do feel like you're dying. It's very, very scary the first time you have a panic attack. So at least one panic attack is followed by 1 month or more in one or both of the following: persistent worry of having more, and a maladaptive avoidant change in behavior from the panic attack. So if you had a panic attack, let's say at a party, then going to your next party, worrying about having another panic attack is what would, qualify for this diagnosis, which happens a lot. Phobia. That's another diagnosis under the anxiety bucket. And the prevalence is very high, 7 to 9% for adults, up to 16% for adolescents. And the diagnostic criteria is a marked fear or anxiety about a specific object or situation. The object almost always provokes an immediate, intense fear or anxiety. The phobic object is avoided, and or if it has to be endured with intense fear and anxiety, and it's persistent, typically lasting for 6 months or more. And so this is like people who have a phobia of going to the doctor, right? People who have a phobia of spiders or heights, right? It takes many, many different forms. And there are fortunately things that we can do. I work a lot with people that have phobia, and we'll talk about certain phobias that may happen in the optometric office a little bit later. But the standard of care is what we call cognitive behavioral therapy, reframing these thoughts about the phobic object, and exposure under a therapist's care of exposing them in a way that increases with exposure so that we can reduce the amount of anxiety under a controlled situation. And so the good news is there are things we can do for phobias. Depressive disorders, again, tie with anxiety, very, very prevalent. And then under this bucket, what we see is as a major diagnosis is what we call MDD, or major depressive disorder. Prevalence is very high, about 7%, and that's conservative. And the diagnostic criteria is 5 or more of the following symptoms during the same 2-week period: depressed mood most of the day, nearly every day; loss of interest or pleasure, what we call anhedonia. So if you're a person who loved to play tennis or golf, you start to withdraw from those activities. And people, your spouse may notice that, like, gee, you haven't been playing golf. You love golf. What's going on? Significant weight loss or gain, lack of sleep or too much sleep, agitation, fatigue, diminished concentration, and recurrent thoughts of death. We can't talk about MDD without talking about suicide and the relevant terms, because language really matters when we talk about suicide. And the source for this slide is the NIH. And suicide is defined as death caused by self-directed injurious behavior with an intent to die as a result of the behavior. We don't say committed suicide anymore. We say completed suicide or died by suicide. Committed sounds like more of an active, this person committed something, did something wrong. Suicide is when the pain of living is too much for a person to bear, so they complete suicide or die by suicide. And words really matter when you're talking about such a sensitive topic. And every once in a while, I'll be watching the news or read an article online or in the newspaper, and I see committed suicide. And I just really want to change that. And so that's why I include this in the lecture. A suicide attempt, or an SA, is an attempt, but actually it was non-fatal, and the intent was there, but it wasn't carried through. So a suicide attempt may not even result in injury, and that's what we hope happens. But sometimes, unfortunately, it does result in injury. But obviously, it's not a completed suicide, it's just an attempt. Suicidal ideation, or SI, refers to thinking about, having thoughts of suicide. And this is far more common than I ever thought before I trained to become a therapist. This is very, very prevalent, and I deal with this every day with clients. And what we have to do when someone mentions that they have suicidal ideation is we have to rate what we think the risk is at the time. And so there are different rating scales. I use the Columbia University Suicide Severity Rating Scale. And basically, all of these scales really ask, tell me more about the ideation. Have you researched any methods? That's number one. Do you have intent to use those methods? And do you have a plan to carry it out? And so depending upon the answers to those 3 questions, we assess through a validated questionnaire, this CSSRS, what the relative risk is and how we proceed with treatment. Self-injurious behaviors, SIB, this is cutting, scratching, burning, punching. So self-directed injurious behaviors. And this is much more prevalent than you would think. And usually people who have SIB or exhibit SIB, they're not looking to complete suicide. They're not even looking to make a suicide attempt, usually. What it is more for a release of emotions, a release of depression, anger, frustration. But we have to be very careful with SIB, even though it usually does not lead to suicide or suicidal attempts. We do need to assess the risk very, very carefully. But there are fortunately things that we can do to help folks that have SIB. And the CDC states the suicide rate increased 35% alone between 1999 and 2020. And let's remember what happened in 2020, right? That percentage has increased beyond 2020 as we navigated through the early years of the pandemic. So it is a public health crisis in the US, and there are some factors that really increase the risk of suicidal ideation, attempts, and completed suicides. Relationship problems at the top of the list, a crisis within the past 2 weeks, problematic substance use, physical health problems, legal problems, loss of housing, financial problems. So not a complete list, but these are the major things that contribute to this public health crisis. So let's relate it to the eye. What are some of the specific eye conditions that can cause anxiety and depression? Well, I don't have to tell anyone here tonight that all sight-threatening conditions cause some degree of anxiety and depression, right? Not a surprise at all. But I've selected 3 conditions that I think were important to highlight. And of course, this is not a complete list. There are plenty of others. In fact, I just wrote an article for Optometric Management that should be published in the end of May or beginning of June on just AMD and depression, right? So we could add this, but I have to make this a 2-hour lecture. So I picked RP, KC, and Sjogren's because there's some really interesting research about anxiety and depression in these eye conditions that I think is important. So for RP, there's a study done in OVS. It was a Korean study of 194 Korean RP patients who responded to an online survey along with 187 matched controls from the general Korean population who obviously do not have RP. And stress, anxiety was reported in 52% of the RP patients versus 29% of controls, highly statistically significant. As are all of these endpoints, depressive mood for at least 2 weeks duration in the previous year was reported by 35% versus 17%, highly statistically significant again. Suicidal thoughts, again, statistically significant, 39% versus 13%, although no significant difference in the number of suicide attempts in the groups. And so one of our roles is to provide support. Here's a link for a really great RP support, top 10 RP online support groups, because these can really be a lifeline for RP patients. KC, this is from the Journal of Ophthalmology, Psychological Aspects and Depression in Patients with Symptomatic KC, 56 patients with KC, 47 matched controls, all completed and were scored on a standardized depression questionnaire. So we have standardized depression questionnaires, anxiety questionnaires. I use them in my practice. One is the PHQ-9. So this is one of those standard depression questionnaires used in all of the research I'm going to be presenting. So the KC patients showed a statistically significant difference between healthy controls with higher depression scores. So it's very, very statistically significant. So depressive disorders appear to be directly associated with KC in both frequency and intensity. And Facebook has an excellent KC support group. And that is a resource that I have recommended to my KC patients. Sjogren's syndrome, anxiety and depression in patients with primary Sjogren's in the Journal of Rheumatology. Again, standardized questionnaire to examine anxiety and depression in patients with primary Sjogren's, N of 62, and age-matched controls. So the Sjogren's patients had significantly higher scores for both anxiety and depression. compared with controls. And this one is personal for me because I did a lot of work in the dry eye space as an OD and worked specifically with the Sjogren's Syndrome Foundation. And that is the best resource you can provide to your Sjogren's patients. It's sjogrens.org. And I've been to their conferences, and they always include a mental health professional, as well as eye care professionals, rheumatologists, and dentists, because we all know that it's a multi-systemic disease and affects lots of different things, and you need to see lots of different healthcare professionals. And so I couldn't recommend more that the Sjogren's Foundation is a resource you need to provide to your Sjogren's patients. Trauma-related disorders. So now we've done anxiety, depression, and trauma. So under the trauma bucket,
Doc, because we had a comment come in, you might be able to feed off of it. I'm just gonna read it to you. It says SIB hyphen seen in children with trauma backgrounds is a sign of needing to cope with deeper pain of trauma, and yes, agree, a form of release. So I'm not sure if you want to feed off of that comment. So
yes,
can you explain
transition.
SIB?
Yes. Well, self-injurious behavior, what we went over in a couple of slides earlier. So that's cutting, scratching, burning, punching, all directed to yourself, right? And we often find that both children and adults, because both children and adults can have self-injurious behaviors, as the person who asked the question or the statement, they're totally correct. There's usually a trauma base to that, and you're trying to release the emotions around that trauma. And it's a perfect dovetail to this slide, because when we talk about trauma, PTSD is really at the top of the list. And prevalence is very high at 3.5%. And what we see with PTSD is that we need to get out those emotions from the trauma that we experienced. And SIB, or self-injurious behaviors, is one way in which we can see both children and adults expressing that, to release some of that trauma, if you will. And so this is exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways. We think it has to be that we need to experience this directly. Obviously, that is something that happens, right? Trauma comes to us directly. For those of you who work in a VA, you're probably seeing a lot of patients that have PTSD from their honorable service to our country, things that they experienced out in the field. But it's not required that it happens to us directly. We can witness it. We can learn that a traumatic event happened to someone that we love. Or we can experience repeated or extreme exposure to details of a tragic event. So just seeing things on television, depending upon how graphic they are, which is why they have disclaimers, you can witness that and still exhibit signs of trauma or PTSD. But SIB is definitely related to trauma and PTSD specifically. So one or more of the following intrusion symptoms, and what we have with PTSD is intrusive thoughts. Just like the word says, they intrude. You can't shake them. It's not like, okay, well, I'm having that thought, I'm just going to shake it away. It's so intrusive that it's very hard to shake away. And so what we have is it's recurrent, it's involuntary, and it can be distressing memories, dreams, flashbacks, reliving the trauma. So intense distress and or physical reactions with exposure to cues, triggers, right? So we're going to talk about some of the things we do in the office a little later that could be triggers for people that have PTSD. And so people who have PTSD will avoid the stimuli that was associated with the traumatic event. So for instance, an exaggerated startle response, if we're doing Goldman with the bright lights in the BAO, or if people are still doing NCT, you can imagine that if someone bristles when the tonometer is coming close to them, this blue figure that's coming close to them, if they have a real strong reaction, we may be dealing with someone that's had a trauma, right? The bright lights of the BIO, that can be a trigger for trauma. So it's important for us to be aware. Bipolar disorders. And the confusion with bipolar disorder is that there are two types, bipolar 1 and bipolar 2. And by no means am I saying you need to memorize all this. I just want to kind of let this flow over you so that you have some semblance of a knowledge that there are two types of bipolar disorder in case a patient discloses it to you. Prevalence is fortunately lower at 0.6%. But what has to happen is what we call a manic episode. And that's a distinct period of persistently elevated, expansive, or irritable mood, at least 1 week, most of the day, nearly every day, with at least one lifetime episode required for diagnosis. So bipolar 1, we need to have a manic episode. We all have days where we feel manic, in quotes. That's not what we're talking about. This is persistent. It's lasting most of the day, almost every day within a 1 week period. It's exhausting. You know when you have a manic episode. And 3 or more of the following symptoms: a sense of grandiosity, lack of sleep, talking very fast. Now, I'm originally from New York. I talk fast. I talk with my hands too, because I'm Italian American. It's a cultural thing. Those things just come naturally to me. This is definitely not what comes naturally. This is not the New Yorker talking fast. This is noticing an increased speed in someone that normally didn't talk as fast. Racing thoughts, distractibility, psychomotor agitation, movements that are uncontrollable, activities with potential for painful consequences, impulse shopping, for instance, gambling. These are the things that we need to look out for. But in bipolar 1, we can also have what we call a major depressive episode. And that's the same symptoms we had for major depressive disorder. Exactly the same, depressed mood most of the day, anhedonia, all the things that we talked about. So while MDEs or major depressive episodes are very common, they're not required for a diagnosis. A manic episode is. That's the difference between bipolar 1 and bipolar 2. Bipolar 2, prevalence is about the same. It requires a major depressive episode, but there's never been a manic episode. What we get with bipolar 2 is a hypomanic episode. It doesn't last a full week. It doesn't have to be all day, every day. It needs to be 4 days or less. So it's a little bit less, but it's still much more manic than what we might experience day to day if we don't have bipolar disorder. And so those are the major differences. So I think it's just important you know there are 2 types and what the basics are.
So there's
Psychotic disorder.
there's some more comments rolling in, more comments, I think, but one question. But someone typed in, it says girlfriend/boyfriend ends relationship, ... Losing employment seems to have limited coping mechanism. So that was just a comment. And
Okay.
then another one just rolled in and says everything that goes, quote, not as planned, unquote, seems to be a major tragedy. Why can't people deal with things without a depressive episode or worse occurring? Worse occurring. So there is a question there. So
Yeah. We're all different as humans, and our capacity to deal with certain things that happen to us in life is different, right? So some people might be, for the same issue that happened, like let's take a breakup, right? For some people, that may really lead them to a major depressive episode and anxiety that's so debilitating that they're having a hard time getting out of bed. Whereas another person might be, okay, I'm able to move on. I recognize that this is a breakup. I'm going to have a little bit of a grieving period, and then I move on. We're all different, right? Also, our brain chemistry can be different. We're going to talk about antidepressants, right? And so for some people, the threshold for a particular event is going to be different. So some of us can brave it out and tough it out. Some of us need more help. There's no right or wrong to that. I think if you need help, seek it. But definitely we're all different as humans, and there are, differences in how we deal with life events that come up. That's the best way I can answer that question. Yeah.
okay, perfect. Thank you.
So psychotic disorders, schizophrenia is probably the one that most people are familiar with. Prevalence, again, is lower than some of the other disorders, which is great because this is very debilitating. And 2 or more of the following symptoms, each present for a 1-month period, at least persisting for 6 months. And the hallmark signs of schizophrenia are delusions and hallucinations. Delusions are beliefs that do not match up with reality. So if someone says the CIA is stalking me, right? That may be true, right? But is it likely? And, so you need to ask questions as to, what does this person do? Are they in a governmental agency, or is this a delusion, right? And there are certain ways that we can kind of flesh that out so we make sure that we're on the right track. Hallucinations are sensory experiences, visual, which is
Oh,
important to
Doc,
us.
I think we lost you. You might have muted yourself.
Did I? Mm,
Oh, you're
No?
good. Sorry. That was on my end. Sorry. That was on my end. I got
Yeah, no
muted.
worries.
Sorry.
Okay, no worries. No, that's fine.
So,
You
okay.
got to love technology, right? So hallucinations, visual, obviously that's in our bailiwick, auditory, olfactory, and tactile, right? And so seeing things, is this a floater, or is this someone seeing something that's in their peripheral vision that's not really there, right? Disorganized speech, we call it word salad. Grossly disorganized behavior and negative symptoms. So this is things we diminish, emotional expression, withdrawing from social experiences. I had the privilege, and I say privilege, of working with patients that were diagnosed with schizophrenia, and I learned a tremendous amount about the disorder and how debilitating it is. And fortunately, there are medications that are very, very helpful, but they have side effects. This is a really tough condition, but there are things that we can do in combination of medications and talk therapy that can be helpful. So could the eyes be a window to schizophrenia? I'm going to tie some research that shows, could it be possible that we might be doing some baseline tests in the office that might alert us early to mental health conditions? And this is very early research. We're nowhere near having these tests in our offices. But in biological psychiatry is a study of 88 patients with schizophrenia and 88 controls, and they looked at eye movements. Most of these studies are looking at eye movement differences with different mental health conditions. And they were recorded during smooth pursuits, fixations, and free viewing tasks. And they had 298 assessments, and they were able to discriminate all cases from controls with a 98.3% accuracy. Now, this is a small study, more research needs to be done, but I want to alert you that this may become more common for us in the future in your practice lifetime. And I think this research is really interesting. Obsessive compulsive disorders, or OCD. Prevalence 1.2%. Presence of obsessions and compulsions, or both. Well, what does that mean, right? Obsessive compulsive disorder, obviously we know that. Obsessions are persistent thoughts that repeat, urges or images that are intrusive, that cause significant anxiety. And with attempts to ignore or neutralize them, it just doesn't work. They keep persisting. Compulsions are the repetitive behaviors or mental acts that we do to drive away the obsessions, right? So if you have someone who needs to check the door 10 times, right? I'll check it twice, right? So we all have a little bit of sort of OCD tendencies, right? I'll usually check the door twice after I lock it. Do I have OCD? No. If I'm doing it 10 times, then I want to kind of talk with the patient. Why are you doing this? What is it that you're afraid of? What's the obsession that's causing the compulsion of you to check it 10 times? Maybe we find out that they were robbed, their house was broken into, it was traumatic for them, and they're trying to protect themselves by doing this compulsion. It's time consuming, more than an hour a day. So this is not something you just do once and one and done. And it causes the clinically significant distress. Trichotillomania is an example of OCD right in our offices, right? It's in the DSM-5 as a diagnosis. And prevalence is 1 to 2%, so it's decent. Recurrent pulling out of one's hair, eyelashes, eyebrows, any region of the body, most common in the scalp, eyebrows, and eyelashes. And the hair pulling is not attributed to another medical condition, right? So we are front and center in diagnosing, trichotillomania in our offices, and this is a DSM-5 diagnosis. So does this person have other obsessive compulsive disorders? Are they seeing a therapist? What's going on? And so that's really direct in line of sight for us. So neurodevelopment disorders, ADHD is at the top of the list. Prevalence is high in adults, double in children at 5%. Persistent pattern of either inattention or hyperactivity impulsivity. So there are basically two types of ADHD. It used to be called ADD, and they added ADHD, attention deficit hyperactivity disorder, because there's an inattention and a hyperactive component, right? So there's really two types, but you can have both, which is why it's not a ADD1 and an ADD2 like bipolar disorder.
All right.
Can the eyes?
While you're chatting about OCD, if that's okay,
Sure.
um, we had a question roll in, or it basically says, would you agree that OCD behaviors are trying to avoid the fear response that may ensure if they don't complete the compulsive action?
That is spot on. Whoever said that, kudos to you. I couldn't have said it any better. That's exactly what it is. We're doing the compulsion. That's why I give the example of checking the door 10 times, because what is it that they're fearing? If they got broken into before, they're fearing getting broken into again. So somehow the brain connects checking it 10 times with safety. And so, excellent comment. That couldn't have been, like I said, couldn't have been better said by myself as a psychotherapist.
And now
Good
I'm
job.
going to take a little privilege here, and then you can guide me throughout this. So maybe it's coming up in your lecture, but I teach about Charles Bonnet syndrome, seeing the images, teach that it is not an irritative hallucination, it's more of a release hallucination.
Yes.
That's done. And I teach to the audience that I have video of patients, and even during the videos when they're talking about this, they'll say, oh, the person never speaks, they never speak. So I try to teach the audience, like, hey, listen, if they don't speak, then it's Charles Bonnet or that irritative hallucination. However, I'm sorry, not irritative, but release hallucination. But
Release.
if they speak, then there's something mental going on. I don't know how to say it. I would say there's psychosis, psychology, something needs to be done. So maybe you can help me as you go through here how to speak to the audience when I deliver that message, to, like, if they are speaking, that's not that release hallucination. It's not Charles Bonnet. So if it's coming up, I wanted to take some privilege here to ask that question.
Sure. No, that's a great question. You're absolutely right. What happens with the folks that have OCD is they're speaking about the hallucinations. They're very forthright about speaking about them and talking about them, right? And that's very different if it's nonverbal. And so you're spot on in the way you are teaching it. And do you make that differentiation when you talk about it? Is that what you basically
Yeah,
cover?
I usually say, listen, if as long as they don't speak and they have the reduced acuity, whether it's like that 2200 vision in their better eye, it's a release hallucination. I teach that it comes from the temporal lobe, that they're being
Yes.
released. And I'll usually ask, like, okay, I got one question for you. Do these ever speak? I'm like, oh no, there are images, there are cars, they're this. And if they are people, no, they never speak. So I never really had someone that said, oh yeah, they're speaking to me. But
Yes.
I always teach that if they are, there's something higher going on than Charles Bonnet. They need
Yes.
some help. They need
Yes.
professional help. So
They will speak freely about what they hear. Someone is speaking into my ear and telling me. They will be very verbal about it. So there's usually no question between the irritive and the release. You can very clearly demarcate it. They will say, so what are the voices telling you? Well, they're telling me to do X, Y, and Z. What does the voice sound like? Well, it's kind of like a whisper. Yes. Does that clarify it for you?
So when that happens, help me out, because this is like, if that ever happens, it's going to happen to me, because every time you talk about it, right, it comes in your office the next day or within the next 3 days.
Yes.
You talked about making that referral to the cataract surgeon. You talked about making that. Who do I refer to? Is that a primary care? Hey, primary care doc, or do I take that step and refer it to? And where would I refer that to? I guess
Well,
I'll let
that's
you
why I
judge.
argue that you should have one or two mental health professionals that you know and trust to refer to. It's never wrong to refer to the PCP, but if you're suspecting that someone has auditory hallucinations with someone speaking to them, the sooner they can get to see a mental health professional, the better. So that would be either a therapist or a psychiatrist, to get a full workup, to ask the right questions to delineate that. absolutely. But the way you're teaching it is correct. What to tell people to do is that is a referral as quickly as possible to a mental health professional if possible. And if you don't, the PCP will have a mental health professional that they can refer the patient to.
Fantastic. Thank you.
You're very welcome. It's a good question. I'm glad you asked it. So, can the eyes be a window to ADHD? Again, this is an eye movement study in vision research, a recorded eye movements, small study, 22 ADHD diagnosed patients with and without medication, Ritalin. We'll talk about stimulants in a while. In 22 control observers while performing a test of attention. Blink and saccade rates were significantly higher in ADHD subjects in a continuous performance task. Medication reduced the saccade rate to control levels and lowered the blink rate. So ADHD subjects failed to suppress saccades and blinks while anticipating stimuli. And so is this a conclusive study that makes a test in our office? Absolutely not. But it's the beginning of research that may tell us that there's a connection here. Neurocognitive disorders. This is Alzheimer's disease at the top of the list. Prevalence way too high at 10% in people over 65 in the US. It's insidious onset, gradual impairment in one or more cognitive domains. The main cognitive domains are complex attention, executive functioning, that's in the frontal cortex, learning and memory, language, perceptual motor skills, and social domains. Genetic testing is important, but all three of the following need to be present: a clear decline in memory, learning, in at least one domain, steady, progressive, gradual decline in cognition, and no evidence of a mixed etiology. Is this a stroke? Is this, a cardiovascular event that's going on? And so obviously lots of research in finding a cure to Alzheimer's disease. Could the eyes be a window? Again, registering eye movements in clinical experimental neuropsychology. Eye movement behavior was monitored in 18 patients, again, very tiny study, with Alzheimer's disease and 40 age-matched controls during sentence reading. The Alzheimer's group visual exploration was less focused, fixations were much longer, and outgoing saccade amplitudes were smaller than those in controls. So these eye movement measures can demonstrate considerable sensitivity and could potentially provide a user-friendly marker for early disease symptoms and progression. Again, we're way away from having this be a test, but I want you to know that this research is going on. So you're not surprised if this comes across in a journal or an article for you. So are we going to do one of the polling questions? Because it was after this slide that the first one was supposed to come.
Yeah, let me do the polling question. And yeah, I can certainly speak to, I think some of the ganglion cell complex, with the OCTs. I'm not sure if you're going to be talking about that. There's some correlation potentially there with some of the neurogenic conditions that are out there. And are you going to be speaking about how AI maybe be playing a potential for some of this with some of these OCTs?
I'm not, because this is so much to cram into a 2-hour
Yeah.
lecture. I
Okay.
wish I could. It's a
Yeah,
great,
that's okay. We can always bring you
it's a
back.
great
So.
adjunct, and I may do a future sort of take away some things and add some different things, but that's one that's on my bucket list to do. Yes.
Okay. So I launched the question. It's been running here for a little bit. It says, which mental health diagnosis has hallucinations as a main diagnostic criterion? Major depressive disorder, schizophrenia, generalized anxiety disorder, and ADHD. And I think you have a pretty good audience here tonight. I'm not sure if I would have been, I guess I could have by listening to you. Looking back here, we have 97% saying schizophrenia.
Awesome. So that's great. This is a bright group. You're listening. That's fantastic. So congratulations. It's a very, very high percentage. So good for you. Substance-related addictive disorders. There's the way the DSM breaks this down is by substance. So alcohol use disorder, opioid, cannabis, stimulant, you get the idea, right? But the diagnostic criteria are the same for any substance. So it's problematic patterns of substance use leading to clinically significant impairment within a 12-month period in at least two of the following. So using the substances in much larger amounts than intended. So there's social drinking versus excessive drinking, unsuccessful efforts to cut down or control the substance use. I want to quit, but I can't. Significant time spent on activities to get the substance, to use it, or to recover the next day from the substance, strong craving or urge to use the substance, and recurrent use resulting in failure to fulfill roles at work, at school, at home. We're all pretty familiar with these basic diagnostic criteria. This is an excellent article that I recommend from Review of Optometry on how drug abuse affects the eye. And, I think this is the best article written on this topic. And I know you all know this. We have the substances, alcohol, caffeine. We know that excessive caffeine can cause myopia, right? We know that with marijuana, we can get, conjunctival injection. But this is a nice list from the article, but I recommend reading the entire article to do a deeper dive of what substances, can do to the eye and how we can pick up on them, right? I mean, talc retinopathy, that's something that I've only seen a couple of times in my practice life, but obviously that's something we need to address when we see that, right? What's going on with substance use in the patient that has that. But, I recommend this article because substances obviously do affect the eye. Other conditions that fall under sort of miscellaneous categories are physical, sexual, neglectful, psychological abuse of children under the age of 18, elders, persons 60 and over. I turned 60 in August, so I'm hitting that next bucket, and a person with a disability. So adults between the ages of 18 and 59. Children with disability are under the child abuse section. So the American Optometric Association, in their standards of professional conduct, say that we have the responsibility to identify signs of abuse in these populations. And your mandated reporting laws vary by state. So I recommend, if you haven't done so, whatever state or states you're licensed in, is to take a look at what those reporting requirements are. They're pretty standard. You need to report within a certain amount of time, and there's certain baseline information that you need to. And you can do that by a phone number or in writing, but there are resources that your state needs to provide to you in order to do that. So I take a look at that if you don't have that information already. And before we go into psychopharmacology, I had only one time in my career had a mandated report of a child that I felt was suspected of abuse. And let me tell you, that affected me psychologically, not to mention the effects on the child and the family. So I bring this up as a topic, not just to remind you that this is part of what we need to do, but that to take care of yourself if you ever have to do this. I hope you never do, but if you do, it can take its toll. And so, speak to colleagues if you need to if you need to speak with people. Do some self-care for yourself. Be kind to yourself if you have to report do a mandated report for abuse, because it can be very, very difficult.
Yeah, I think
So
a close parallel to that is I have to take child abuse in Pennsylvania, but Florida has to do human trafficking, and I've sat through those lectures before on human trafficking, and that would be something that would probably be, also, tough to weigh in, try to help that person that's under 18 that's being human trafficking, sex trafficking, and then trying to report that. That's kind of like a close parallel to that as the child abuse. So.
Absolutely, and that takes its toll. If you are the reporter, right, your heart goes out, and that does take its toll on you psychologically. And so it's important to take care of yourself so you can do the right thing for your patients. Absolutely, yes. So Psychopharm 101 for the OD. I could do a 2-hour lecture on this alone. So I've really condensed it. Fortunately, for the majority of the psychotropic medications, there are few ocular side effects, and most of them are very, very mild. So that's the good news. Why I do this is that I take the major class of medications that you will see on your intake form, or if patients relay that to you verbally, so that you're familiar with the top line medications and what some of the top line ocular side effects are. So the most common medications for anxiety, GAD, generalized anxiety disorder, are listed here, and there are a couple of classes. Benzodiazepine, known as benzos, their mechanism of action is increasing the action of gamma aminobutyric acid, GABA. And the major ones that you'll see are Klonopin, Ativan, and Xanax. There are others, but these are the major ones that you probably see on your intake form. The watch out for benzos is they're physically addicting. And so these should be prescribed PRN only. And if they are not prescribed PRN, then there can be a problem with the patient getting addicted to them. So none of the other medications in this grouping are addictive. So benzos, we really need to be careful with that. And so they should only be prescribed PRN. SSRIs, I'm sure most, if not all of you, have heard of this class of medications. These are selective serotonin reuptake inhibitors. All of these medications for anxiety and depression are really mitigating neurotransmitters, right? And so if you prevent the reuptake of a neurotransmitter, you increase it in the synapse, right? And theoretically, that should help it to work more effectively. And so that's the mechanism of action where serotonin is the neurotransmitter. And so that's what SSRIs are. And that's, you'll see Zoloft, Wellbutrin, Celexa, Lexapro, Prozac. These are the most common ones that you'll see. SNRIs are pretty much the same thing, but in addition to serotonin, norepinephrine is the inhibition of the reuptake of both of them instead of just serotonin, right? But it's a very similar MOA. Effexor, Cymbalta are two examples in this class that are very widely prescribed. Buspar stimulates serotonin and dopamine receptors, and that is the name of the class of the medication as well as the medication itself. And the ocular side effects are very rare. You can get mild intermittent blurry vision from mydriasis or cycloplegia, but we're talking very minimally with the SSRIs and the SNRIs due to an anticholinergic effect. And we could also see a slight increase in IOP. Again, it's not going to shoot the IOP up tremendously, but if you're noticing a variation and you can make a connection that someone's recently started an SSRI or an SNRI, then maybe that can explain a little bit of the difference. All of this information on psychopharmacology comes from an article that I absolutely recommend called The Mind's Eye, Ocular Complications of Psychotropic Medications by a review of Optometry in January 15th of 2016. Print it out, save it as a PDF. It's a great resource for you to have. I've surveyed both the ophthalmology and optometry literature. This is by far, in both camps, the best thing that's ever been written on this topic. So that's why I list it here so that you can go online and get a copy of it. So for MDD, for depression, we see some overlap. The SSRIs and the SNRIs are used for both depression because they're known as antidepressants, but they're just as prescribed for anxiety. And so there's overlap with medications for depression and anxiety with the SSRIs and the SNRIs. So all the information, the names are completely the same. But under antidepressant medication, we have tricyclic antidepressants, or TCA, and they increase norepinephrine and serotonin. So again, we're talking about neurotransmitters, right? Amitriptyline, Ascendin, Norpramin are the major names that you'll see on your intake form. Then we also have monoamine oxidase inhibitors. These are prescribed less these days, but you may see them. So the mechanism of action is really unknown, but it's some mediation of neurotransmitters as per usual. And some of the major medications are Nardil, Zellopar, and Marplan. And the ocular side effects, again, the same because the SSRIs and SNRIs are the same. And the TCAs can also have an anticholinergic effect and a slight increase in IOP.
All right, Doc, I'm going to take some privilege here again. I got a question for you.
Sure.
So I do an opioid course, and it's the required course. It's a 2-hour course, and we've gotten down to where hydrocodone is a good medication for eye pain, but I always teach that tramadol is optometry's medication. 50 milligrams, 100 milligrams. However, hydrocodone has the Tylenol in it. It goes after the mu kappa receptor, so on and so forth. Tramadol it's a dual action. Mu receptors, it inhibits the neuronal uptake of serotonin and norepinephrine, which we need to be careful with these medications that you're talking about. So I guess my question I'm now boiling it down to is, since we're using this just for acute pain, someone has a large corneal abrasion, we want to use tramadol 50 milligrams, 100 milligrams over the course of 1 to 3 days.
Yes.
Do we have to be careful? I know that we have to be careful, but what's the severity of carefulness, I guess, with some of these medications that are these inhibiting the serotonin and norepinephrine?
Yes. That's a great question. 1 to 3 days, not so much. You know, depending, so what I would say to really sort of cover yourself is, to let the patient know and to let them, so if their PCP prescribed their psychotropic medication or a psychiatric practitioner, to let them know that, they're on this medication for, just a couple of days, and that at least you're completing the loop. But there really shouldn't be any major issues with that. Have you encountered any in your practice or?
I have not. I've kind of gone on to the kind of like, hey, we're going to be on this for 2 days. Take as little as you can. We're going to report it to your doc. I've never really heard anything. Yeah, I've been following the patient back because it's a corneal abrasion.
Yes.
Nothing major seems to be happening, but again, kind of being a teacher of that course, if I want to be able to relay something different, I wanted to reach out and ask you as an expert in this arena.
No, you're doing exactly what I would recommend people to do, just keeping everyone informed. It's where we get into problems if people are using these medications beyond what you're prescribing, right? And that's a different issue. But in the sort of 1 to 3 day period, your clinical practice is indicating what I understand to be true, which is that it should not be much of a problem, but just notify whoever the prescriber is of the psychotropic medication.
Perfect. Thank you.
Sure. So antipsychotic medications, these are really intense medications that can have a lot of side effects. And obviously we'll see for the eye, but a lot of side effects, just in general, right? So atypical antipsychotics are second generation, and they're more commonly prescribed now. Typical antipsychotics are the original first generation. We really shouldn't be seeing those anymore. And so the atypical mechanism of action, unclear, but again, we're back to dopamine, noradrenaline, serotonin, acetylcholine. That's a suspected mechanism of action, but we don't really know exactly what the MOA is for the atypical antipsychotics. Some of the major ones, Abilify is one that probably saw on television, Latuda, another one, Clozaril, Zyprexa, Invega, Seroquel, Risperidone. So when I was working exclusively with clients that were patients that were diagnosed with schizophrenia, I would see these medications every day. And I would work with a nurse that was tracking, whether or not they were compliant with the medications. Because here's the thing: the medications work, but if you skip them or stop them, then all bets are off. All the symptoms, the delusions, the hallucinations come back. The typical antipsychotics, the first generation, Thorazine, phenothiazine, we should not be seeing this. I mention it to say you should not be seeing it. So if you do see it, it is a red flag. But largely, this is not going to be widely prescribed anymore. Ocular side effects, mainly the first generation, the typicals: blurry vision, diplopia, decreased mucus and tear production, ocular pigment changes all over. lids, conjunctiva, cornea, lens, the retina, along with lenticular opacities. So of all the psychotropic medications, these are the typical antipsychotics that are not as widely prescribed anymore or prescribed really at all are the ones that have the major side effects. The atypical, really not too much in terms of ocular side effects, fortunately. Bipolar medications, lithium, Tegretol, Depakote, Trileptal, reduces the excitatory, right? Because mania, we want to damp down the excitatory. And so glutamate, dopamine, but increases inhibitory GABA neurotransmission to quell things down. For bipolar depression, Latuda, lots of TV commercials, you probably heard that, Lamictal, Seroquel, and Symbyax. Unknown mechanism of action, but again, central dopamine and serotonin receptor antagonism is what's believed. What's interesting with lithium, which is widely prescribed still, increased tear film osmolarity. So if you're measuring tear film osmolarity, sodium levels go up. So you may see a blip in that with someone who's on lithium, which I think is interesting for us to be aware of. And with Lamictal, you can see nystagmus and diplopia, but only if they take more than it's prescribed, if there's an overdose. Most common ADHD medications are stimulants. They're a central nervous stimulant, speeding up your brain activity, increasing dopamine and norepinephrine in the brain. Because remember, the inattentive, lack of focus, we want to stimulate the brain to stay more focused. And that's why stimulants are widely prescribed for ADHD. We mentioned Ritalin already, Concerta, Adderall, Vyvanse, Focalin, Provigil, and antidepressants can also be used. So not just stimulants. Stimulants are usually first wave. And then if the stimulants have too many side effects, you can switch to Strattera, which is an SNRI, or Wellbutrin, which is an SSRI. And obviously the ocular side effects are myokymia, just like if you drink too much coffee, have too much caffeine. So MPOD, blue light, and cognition. Why am I talking about MPOD and what's the connection between MPOD and cognition? I think it's a fascinating one. So I included in this lecture.
So Doc, good. I was going to say we get a lot of comments that there's all acronyms out there, and you have it right there: MPOD, macular pigment optical density.
Yes.
Some of the survey results is we use as we do multiple lectures, we get people coming in using all the acronyms, and they just like them to explain. So I was going to say macular pigment optical density, but you have it right there. Perfect. Thank
absolutely. You. Yeah, we need to explain the acronyms, right? We can't assume that people know them, especially when I'm talking about mental health acronyms, right? But MPOD, yeah, I mean, not everyone's necessarily going to know what MPOD is or measure MPOD, right? It's relatively new to our profession. It's been around for a while, but not forever. But that's exactly what it is. It's the macular pigment optical density. So the density of the pigment within the macula. And it's why that's important is that MPOD, it's a measurement of the attenuation of blue light by the macular pigment. And it's linearly related to the amount of lutein and zeaxanthin in the macula. And that's why it's important for us to either get those micronutrients from the diet or from supplementation. And the measurement is in optical density units or DUs, and it varies between 0 and 1. So I have a very colorful schematic of, what does this really mean when we measure MPOD? And so I don't know if you can see my cursor, but
yep, we can.
If we have 0 MPOD score, right, because it goes from 0 all the way to 1. If we're in the red zone here at 0, 100% of the harmful blue light is not being attenuated, right? And so we know that blue light is harmful for the macula. It's harmful for a lot of things. Blue light is everywhere. Tablets, cell phones. I'm in front of my laptop. I'm getting exposed to blue light. I have my blue light lenses here to help with protection. And then we go all the way from 0 to 1, where only 3% of the blue light is really basically getting through. So it's like our internal sunglasses, right? to protect us from blue light. And so we want this score to be as close to 1 as possible. And if it's not, then we need to either increase in our diet zeaxanthin and lutein or through supplementation. And so that's basically what MPOD measures, why it's important to help protect the macula. Could it be a biomarker for cognition? We know biomarkers are, anything objective test that we do, like an A1C or C-reactive protein, HDL, LDL, right? Could MPOD be a biomarker for cognition? And there's some interesting research that indicates it may be. And again, this is, cursory research. There's more research that needs to be done. This is from a journal called Age and Aging, where older adults, 108 of them, 77 plus or minus years old, serum carotenoids, lutein and zeaxanthin were measured. So they actually did a blood test, and MPOD was assessed, right? And so MPOD levels were significantly associated with better global cognition, verbal learning and fluency, recall, processing speed, and perceptual speed. But only the serum lutein and zeaxanthin was significantly related only to verbal fluency. So when we measure serum versus MPOD is much more correlated with cognition in the cognition test that they did in this research. So more research needs to be done. But again, this is something that if you're an OD and you measure MPOD in your office, could this be a test that could indicate a decrease in cognition earlier on? And that's where the research is trying to go. Another study, smaller study, 24 subjects with mild cognitive impairment. This is in the neurobiology of aging. Were compared with 24 matched controls. And for the subjects with mild cognitive impairment, MPOD was related to cognition in the following ways. All of these statistically significant, including the composite score on a mini mental state examination. So a mental state examination is what they did. And they look at visual, spatial, and constructional abilities, language ability, attention, repeatable battery. In older adults, MPOD was only related to the visual, spatial, and constructional ability. So we can see that for those that had a mild cognitive impairment versus just healthy older patients, MPOD could be a biomarker for these various aspects of cognition. So these are 2 initial research studies that show promise for further research in seeing if this can be a biomarker.
So with that being said, Doc, I work kind of in that functional arena. I know the MPOD, I can speak about the MPOD, but I use the hand scanner, the Pharmanex hand scanner,
Yes.
At which, there was an ARVO study that correlated what's in the palm of the hand is what's in serum, is what's in, more importantly, what's in the macula. When you said about that serum versus retina, my clear conclusion was, okay, if it's in the blood, it doesn't mean it's absorbing into the tissue,
Yes.
right? So that's why I kind of like using the hand scanner or the MPOD. The MPOD's more of a subjective test, where the hand scanner is more of an objective test. And they're kind of using the hand scanner too to go along with those cognition, the type of conditions, the Alzheimer's and so on and so forth, neurogenic. And I just want to remind the audience that, lutein and zeaxanthin are carotenoids, which are just one part of the whole antioxidant system. And, one of the ways, that I'm trying to help with optometry, and Dr. Pardo's here helping with this excellent lecture here with mental health, is that, when someone scores low in lutein and zeaxanthin, they're just not just low in lutein and zeaxanthin, they're low in the whole oxidative network. So I'm trying to help, like, okay, replace that whole antioxidant network. And if you want to target with lutein and zeaxanthin, go right ahead. But lutein and zeaxanthin and a comprehensive antioxidant are probably the way we should be going.
Yes, absolutely. That's a great point. Yeah, because it's not just about L and Z. It's about the totality of the things. If they're low, then the others are going to be low. Absolutely. Yes.
Fantastic.
I think
Yeah,
we're
great.
on to our third polling question.
Okay, well, let me fire that up here. I can certainly do it now. I have that we did the last one. I can do polling question number 2. Let's see here. I'll open that one up.
Yeah.
It says, which mental health diagnosis may present with startle response from Goldman tonometry? Did we talk about that one?
Yep.
Which mental health diagnosis, oh yes, present with a startle response from Goldman tonometry? I got you. We've got them rolling in nicely here. We've got about 8 responses, 18 responses, got 19 responses. And I can do polling question number 3 after this if you'd like to.
Sure,
So,
let's do that. Yeah, I forgot to remind you of the second one, so
okay,
my bad.
no worries. I usually tell the speakers to drop a polling question slide in there, but that was my fault. I didn't tell you that on this one. So,
Yeah, Vanessa told me just what's the number of the slide, so I just wrote it down what I sent her.
so we'll display this and we'll end this pretty quickly. You've got 92% saying PTSD. So,
Excellent.
and then we got 3%, 2% for the other one. So I'll close that question and
Good
close
job.
that display. And let's go down to polling question number. This is what makes this synchronous. This is the live and interaction. So this all is kind of being recorded in the background for us. So we don't want to be showing that yet. So the question is open. Which class of psychotropic medications for ADHD may cause myokine? Is it the benzodiazepines? Is it the SSRIs? Is it stimulants or atypical antipsychotics? Thanks everyone for making this a synchronous virtual by replying to these polling questions. The polling questions can be found on the right side. It says chat polls. If you click on that, it should open up the polling question. All right. Looks like people are rolling in there. I'll display. Ooh, we got. Okay. So what we have, Doc, is we have the benzos for 24%. We got the SSRIs at 12. Stimulants at, ooh, just dropped from 61 to 60. And we got the atypical antipsychotics at 4%.
So it's stimulants is the answer. So it seems the majority of people got the stimulants right. Yes.
Yep,
So think
56.
stimulants and caffeine causing myokine.
Fantastic.
Terrific.
Let me check the
So
chat here before you get rolling here. Let's
sure.
see. Way back, someone asked about, are you aware of any research regarding the abnormal ERG response in Alzheimer's patients with normal retinal health? I am aware of that, but if you want to comment on that, if you're aware.
I am not actually. So if you can speak to that, that would be I would really appreciate that.
Yeah, I mean, there's, as mentioned before, ERGs, OCT, kind of the eye is the connection to the brain. We have that ganglion cell that in that ganglion cell and the nerve fiber layer, the ganglion cell dies. But if we remember that tract of how it goes through the nerve fiber layer over to the neuroretinal rim, through the optic nerve, lamina cribosa becomes myelinated, and then synapses back in the lateral geniculate body. Ganglion, then, signals get sent back to the occipital lobe. Damage in those areas cause retrograde. So then, obviously, measuring it with an OCT, measuring the pulse with ERG and the VEP testing. There's certainly some correlation, but then teasing out all the other issues, whether it's glaucoma or all the other retinal conditions and nutritional conditions, make it hard to say yes, Alzheimer's, so on and so forth.
Yes.
So then, any thoughts on macular ganglion cell measurement in Alzheimer's? Yeah, that one just rolled in, and yes, let's stay tuned. I think maybe AI might help us out and tease those things out to maybe give us a higher correlation to these neurodegenerative conditions. Um, I see some pretty funky GCCs. We have a good wellness program, and there's times when I just scratch my head going, "Ugh, this pattern, I wonder if this is a sign of something for this person in the future." But we just don't have enough confidence to go and say that. Or how do we make a referral? Who would I make that referral to? So yeah, our instrument, we always say the eye and brain are connected. I think stay tuned. I think, probably things will be rapidly developing over the next few years in this arena.
Yes, but I wasn't aware of any definitive research that locks that in. So I was curious if you do.
Yeah, yeah, I don't think there's any specific. I think there's just a lot of, geez, there's correlations.
Relations,
Look at
yes.
this person. There's just relationships, but I think they're trying to look into the research and how it to be done. So
Yes, exactly. Similar to some of the connections I'm making, is this a window to, is this the eye a window to this, right? This is like cursory research that's not congealed to like a definitive thing yet, but we're on to something, because the eye and the brain are inextricably connected. And so I think, it's a frontier that's very exciting for us, I think, as optometrists. So case studies, these are sort of anecdotal, the real cases, but I just kind of talk through how does this relate to everyday practice, and so the first case is a 19-year-old college student um, that came to me as a therapist at one of the university counseling centers that I worked at, and she put on her intake form under medical conditions keratoconus, which was misspelled, and said in parentheses, "I don't expect you to know what this is, so I will explain when I come in for the appointment." And lo and behold, I happened to be an OD who was this person's therapist. And I absolutely knew what keratoconus was. And we had a real conversation about her mental health journey with keratoconus. She actually became suicidal um, because she was going from doctor to doctor and just wasn't getting the answers and an understanding of what was going on with her eyes that she really needed. And the Casey had progressed to a certain level that her vision was not where she would want it to be. And then finally, an OD had suggested corneal cross-linking, and that changed her life. And so she was coming to me for other things, but wanted to let me know about her history of depression and anxiety from having keratoconus, and that's where it started. And she wasn't having any more suicidal ideation, which was great. And we were working on other issues, transitioning as a freshman in college. But I really appreciated that she talked to me about this, because I'm talking about this topic and that this actually affects patients' mental health, right? With keratoconus, with Sjogren's, we go to from doctor to doctor to doctor. Sjogren's on average takes 5 years to get a diagnosis. So you go to the rheumatologist, the dentist, the optometrist, the ophthalmologist. Sometimes the dots aren't connected. And so these people are going round and round in a clinical circle and they're not getting any answers. And so that's what causes the anxiety and depression is, not knowing what I have, right? But here we saw someone that had an eye condition that caused severe depression and anxiety. And largely those mental health conditions were resolved by the right clinical treatment of the eye. And so this stuff really plays out in our practices. When I was an optometrist, I had a 22-year-old who was a new patient to me. I dilate every patient and told me he had a history of a phobia and fainting with dilation. And I had never heard about this, right? And so we talked about it. And I said, "Listen, would you be willing to try again?" And he was like, "I'm willing to try again, but I know that it's not going to work." And I said, "Okay." So what I did was I used sort of a grounded breathing technique, because this was a phobia, which is a form of anxiety. And so getting the patient grounded in the chair means, okay, I want you to feel your back supported by the back of the chair. Want you to feel your legs supported by the bottom of the chair, your feet supported by the footrest, and everything is supported by the office floor, which is supported by the earth. And I want you to take a couple of breaths with me. We're going to breathe together. I'm only going to do one drop and see how you're doing. And then we're going to check in. And if you faint, I will know what to do. So I don't want you to worry. I'm here, and we'll be in constant communication through this process. And he said, yes, let's go for it, because I really want to get my eyes dilated. And we put the first drop in, and he started to, breathe a little heavier. And we did the grounding technique. We did the breathing together. You're doing okay. I'm here. I'm here. And he was able to work through it. And I said, I'd like to do a second drop. Are you up for it? We could do it with just the first drop, but what do you think? And he said, no, let's try it. So the second drop, he had less of a phobic reaction. We still did the same thing, and we were able to do a dilation. And he came back to me year after that, and we did a dilation every time. Now, there was an element of luck involved in this. I'm not going to say that there wasn't, but taking the extra time to explain to the patient, you get what they're saying, this is real, you validate it, and then you ask permission if they'd be willing to try it again, and tell them how you might do it differently this time to make it a more comfortable experience, and that you are in control. I will stop at the first drop if it's too much for you. And that was able to get us through. So this was a true phobia of getting dilation drops, and completing a dilation. And so again, this stuff happens. And then the last is, I was a clinical preceptor at one of our external clinics in Boston. And it was the last semester, and I was precepting fourth year students. And my best intern I ever had came in, and he was really visibly upset. And he had a 21-year-old recent college grad who had RP. And she had no idea, obviously asymptomatic, just starting out her professional life after finishing college. And he was really visibly shaken up about having to deliver this news. So delivering bad news is something that can really deplete us psychologically, right? And so the two of us talked for a little bit in my office before we went in. I said, I will take the lead in presenting this news. I want you to chime in whenever you feel comfortable, but we'll do this together. We got resources together. We made a referral to a friend of mine who's a vitreoretinal specialist that I refer patients to on a regular basis. And we had a whole plan that we did together, to present all of this information in addition to the diagnosis. And so this stuff really happens in our practices, and the psychological issues crop up. And so I use these three experiences that actually happened to me to illustrate, this is why I did this lecture, to provide more tools for ODs to be able to, deal with some of the issues that come up. So before we wrap up, number 4 is the next question, polling question.
Oh, let me get that rocking and rolling here. And let me read and I can help answer this question while the polling question is going on. It says, have there been any studies about antioxidants improving Alzheimer's symptoms? Have there been any studies about antioxidants improving? And while the polling question is going on, if you want to take a crack at it, Doc, go ahead, or I'll take a crack at it. And
I've been in that sort of eye care supplement world a lot and have lectured extensively. I have not seen really definitive research that shows a direct correlation of symptom reduction. But certainly I may not be aware of something that's recently broken. But I'm not aware of any definitive research that would indicate that.
yeah, and my reply would be, since I'm playing around in this functional medicine type of space, I really think that's going to be one of optometry's. What's the best healthcare out there is prevention. I think it's going to be part of optometry's role here in the future, as we kind of max out lasers and so on and so forth. I think what we have to look at is, this is not an acute problem like a corneal abrasion, a marginal ulcer, contact lens overwear, where we can kind of do linear and short-term studies like, hordeolum, if we use an antibiotic, it helps, shorten the duration. maybe it goes away in 6 or 8 weeks on its own, but we can use an antibiotic, so on and so forth. These are chronic conditions: diabetes, rheumatoid arthritis, macular degeneration, Alzheimer's, and the neurodegeneration and neurodegenerative conditions. And we really can't do randomized clinical trials like that because these systems are not, linear or binary. Do this, you get that. Alzheimer's, give them an antioxidant. There's the gut microbiome. But what there is evidence informed, risk adjusted medicine. We can go and when it comes to supplements, you can't really say it's treating, they support, right?
Yes.
If it could treat, then it would be a drug. So the key comes down, the supplements are, if you're using a fatty acid, omega-3s to help balance out those sixes, is there evidence informed risk adjusted medicine that would say that would support the brain, since the brain is majority fat? And then does that help the cell membrane to then absorb those antioxidants because of the phospholipid bilayer? So we have this evidence-informed risk-adjusted medicine. Are there studies that say that it treats? It's kind of hard to do that in a long-term study that's out there. So you kind of have to kind of fall back into, are you supporting, are you giving the patient the best help whenever you do that? And I think there's evidence out there for that. It's just, is there things that shows that the patient's memory get better? Probably not that type of research. So.
No. Yes, I agree completely.
All right, so with that, which psychotic medication may increase tear film osmolarity? I just hung out with Carrie Kelson, one of the major players of that device, and we have lithium being 67%.
Good, because that's the right answer. Yes, and I actually worked with a person who was really the initial developer of measuring tear film osmolarity. My first job in medical affairs, Dr. Jeffrey Gilbard, who is a corneal specialist, and so measuring tear film osmolarity is near and dear to my heart. I think it's really important. And I have no financial connection with any company, but I think it's important. But lithium is the right answer. So good. So what about for us, mental health for the optometric physician? The AOA did a survey of physicians, including optometrists. The American Optometric Association obviously did this, but they included all physicians. And in 2017, 60% of them feel their work schedule hinders family or personal time, compared to only 40% of the general workforce. And 44% of us report feeling burned out, as compared only to 28%. The good news is, when we look at healthcare providers, when I did the plenary at this year's Academy, the biggest honor I've ever had in my career, one of the folks was the chief medical officer of the Ohio State University, not the optometry school, the whole university. And she was amazing. She was one of the 3 panelists, including myself. And she did a survey, and optometry, as it relates to physicians, dentists, nurses, we do very, very well, like overall, in anxiety, depression, and burnout. But we still can have it, right? And so what do we do about it? Well, fortunately, there's a greater openness and acceptance of therapy and much less stigma. And COVID really accelerated that. People found that their mental health issues were really getting so bad during the pandemic that they sought help, and they weren't letting stigma stop them. And that's a good thing. More and more people, I am completely booked. All of my colleagues are completely booked. And that is because people are seeking care, and that's a good thing. We have an alphabet soup, just like we do in eye care. We have 3 O's. There are many more than 3 in mental health. Therapists can be licensed mental health counselors. They can be clinical masters in MSW and in clinical social work, like I am. They can be a PhD psychologist. They can be a PsyD psychiatrist. The psychologist, the difference between those two is PhD is more research oriented, PsyD is more clinically oriented, but they can both see patients. And then, of course, we have psychiatry, and that would be psychiatric nurse practitioners and psychiatrists, who mainly these days write scripts. most are not doing therapy, they leave that to us and we refer to them for scripts. So you can do individual, couple, or group therapy. The other thing that can be helpful is to have a practice staff discussion or support group within the practice, right? If you have weekly meetings, devote a little bit of time to, what's going on? How is everyone feeling? You'd be surprised in a podcast that I did with the Power Hour how that can be help increase productivity in practice. And so getting issues out, if someone needs to take a mental health day, to be aware of that they will come back after having that day to be with themselves and deal with that mental health issue much more productive than they would if they just came in and tried to grin and bear it. And so that's important. But we can go to therapists just like anybody else because we're human too. Talk about EMDR, eye movement desensitization and reprocessing. This is something that not every therapist has. In fact, most don't. I am an EMDR trained therapist. It's very expensive and it takes a lot of time, but this is the standard of treatment for PTSD. It's for trauma. The only reason why I put this slide in here is that you'll see eye is in the word and you'll see a finger moving across. What EMDR needs is bilateral stimulation. So when it was developed, the bilateral stimulation was we have two eyes, and so we're stimulating both eyes by having them follow a finger. It has nothing to do with the eyes as far as we know. I do it with tapping of the shoulders or tapping on your legs because I'm a virtual practice only, and this is not as effective as this because they can see visual cues. I do it along with them. But it's just a bilateral stimulation. Because eye is in the name, I would never want you to be caught off guard. This doesn't really have anything to do with the eyes at all, other than eye movement can be the way you do bilateral stimulation. But particularly if you work in the VA, this is the gold standard for treatment of PTSD. And as such, I think you should be aware of it. And, this is what it looks like. It's bilateral stimulation. It can be used for a variety of things, but it's the standard of care for PTSD. But it has nothing to do with the eyes. Optometrists don't do EMDR, therapists do, but I do want you to be aware of it. So our last survey question before I wrap it up.
I will open it up right now. The question is being opened. Okay. MPOD is a potential biomarker for anxiety, depression, cognition, ADHD. MPOD is a potential biomarker for anxiety, depression, cognition, and ADHD. And they're rolling in here nicely, Doc.
This one might be a clear winner.
And for the sake of time, we got some more rolling in. We have 66% with cognition, with the runner-up being depression at 21%.
Okay, good job. All right, so to wrap it all up, I started with this. Why did I think that this is relevant? So I review this at the end because I hope after having the lecture, you can see that these points are really important and why this information can be very helpful to modern optometric practice. So with the PCPs of the eye, right? We talk about maybe the first one to find diabetes. I've given you some research that indicates we may be the first one to pick up some mental disorders down in your practice lifetime. Mental health is a public health crisis. We need to provide collaborative, holistic, and integrated care. So that's why we talked about why it's important to have, in Dr. Caldwell's question, like, what do you do if the person has, delusions and they're actually saying the person is speaking to them and they're speaking about the person speaking to them, they're verbal about it, is you need to have one or two good mental health professionals to refer. And more and more of your patients are taking psychotropic medications. I'm sure you recognize the majority of the names of these medications because I'm sure you see them every day on your intake forms, and the ocular side effects that are aware of them. And that it can be a two-way referral source. They will thank you by referring patients back to you. So, and then serving your community, continue to do your screenings at schools, at health fairs, to provide that information and resources, including mental health resources for your patients that need them, patients that you diagnose with sight debilitating issues. So with that, here is my email address. If you have any further questions, feel free to reach out to me. I will get back to you as quickly as I can. And if we have any remaining time, I'll take, any questions before you do your wrap up, Dr. Caldwell.
Yeah, that's fantastic. No other questions have shown up in the box here. If anyone has any questions for Doc, please put them in the chat box. If not, we'll wrap up here shortly. I think I asked all my questions along the way. I certainly appreciate you letting me ask my questions along the way. It helped me be a better clinician.
Questions are my favorite part of doing a workshop, a webinar. I love the questions, the best part.
Okay. You're getting now the virtual round of applause is starting to roll in. You got a wow. Glad I tuned in type of no questions rolling in.
Very kind.
That's fantastic. No, this not only met the expectations, I'd never heard the lecture before, and not only did it meet the expectations, it exceeded it. It was fantastic. So,
oh, that's very, very kind of you. Coming from you, that means a lot. It really does. Thank you.
all right. So let me share my screen. If you stop unsharing, that would be fantastic. The little red dot appeared. Couldn't have timed that any better, Doc. Look, we're like great dance partners here. If everyone would look right here on their screen, you would see that there is a little red dot there. That means the survey is open. That's the post-event survey that is required when we do these events. Vanessa takes care of all that for us. So that's where the survey is. I'm going to take one more quick look. EMDR, how many sessions do you believe it takes before some relief for PTSD?
Great question. That'll vary by the level of trauma, but generally, you definitely need to have at least 8 sessions minimum to see any progress with EMDR. But generally, I'm doing more than 8 sessions depending upon the level of the trauma.
So,
Very
Doc,
effective.
I'm not sure if you, because as a host there, if you're able to click into the chat box there and up in the upper right-hand corner there, if you're able to see that or not. But your virtual round of applause is rolling in there. Thanks, Dennis. Good to see a fellow Noenco grad. Great one. Thank you. Thank you. Thank you. Exceeded my expectations. They're rolling in there. So,
That's very kind. Very kind.
With that bit, I don't see any more questions. So thank you for doing this. This will conclude the intersection of optometry and mental health. This was a synchronous virtual course by Dr. Dennis Pardo. Thank you again, Doc.
Thank you so much, Dr. Caldwell. Have a great night, everyone, and thanks for attending.